into lecture 23. Continuing on talking about some transfusion reactions, some adverse effects of transfusion. This lecture, we're going to concentrate on delayed transfusion reactions, okay, and a few other non-immune related transfusion reactions. All right, so just a reminder, here's our division. What type of transfusion reaction? Is it acute or chronic? Or not chronic, but delayed. Acute meaning that it occurs less than 24 hours from the time of transfusion. Delayed would be greater than 24 hours. Okay, keeping in mind a delayed transfusion reaction might happen 28 days later, or whenever your donor facility determines that your donor unit was positive for an infectious disease. Okay, so at whatever point the recipient pops up to be positive for that infectious disease, that is considered an adverse reaction of a transfusion. Okay. So it is possible to have hemolytic transfusion reactions that are delayed. All right, symptoms might not occur until 7 to 10 days later. This would be an example of our KID antibody. All right, that it does cause hemolysis, right, because the spleen is involved in taking out those antibody-coated cells. Okay. Transmission of infections, like I mentioned, iron overload, graft-versus-host disease, alloimmunization, meaning that we transfuse that patient red cells, and now 2 months later, they have developed an antibody, all right? And then depletion of coagulation factors due to DIC. All right, so let's talk about delayed hemolytic transfusion reactions. Again, this can occur days to weeks, 5 to 7 days. They might present with symptoms of anemia, but it could be ultimately 28 days, okay, later. This is when your amnestic or secondary immune response is occurring. All right, so what's happening is the patient's previous antibody was at such undetectable levels that BloodBank did not detect it, but it was actually there. Sometime in the past, they had already built that antibody, and then we exposed them to the antigen, causing their titer to go up. All right, so now that titer is active, or that antibody is active, coating the donor cells, the spleen is going to take them out. That's why it's a delayed reaction, okay? There's actually statistics show that there's a 1 to 2% risk of sensitizing the recipient to antigens other than D. All right, so KID is the one that is notoriously associated with delayed transfusion reactions, but you can also see it in your RH family. So D, big C, big E, little e. You can also see it in your Duffy family, and they're just not as notorious for dropping to undetectable levels. Right, KID is the one that titer will drop. Okay. I've seen big E, and you'll see this a lot in BloodBank. You maybe 5 years ago, the patient came to your facility, you identified big E, and now you have the same patient, and his big E is not reacting. All right. What would happen if you didn't have that patient history? You would not know he had anti-E. All right. So you could potentially give him big E positive units. All right. So it's common some of these antibodies might drop to undetectable levels. And also something you guys need to be aware of, anytime BloodBank identifies an antibody on a patient, that patient is forwarded what they call an antibody card. It has a statement from the identifying facility, and it says on such a date, BloodBank identified this antibody in your plasma. You need to present this card at every hospital admission, right? To let the clinicians know that you have an antibody. They will let BloodBank know. Do you think the majority of your patient population knows what that means? No, and so oftentimes you will get calls from patients saying, I got this antibody card in the mail. What does that mean? So you're working the bench, very hard to take time to explain the antigen antibody complex to patients. You should have a quality assurance officer that you can forward that call to, and they can handle it, all right? That will happen, all right? So you'll get, and if you have time and you are willing to discuss that, you can tell them. The ultimate thing they need to know is anytime they are scheduled for surgery or they present to the ER, they need to present that card, right? It's kind of like if they have a latex allergy now, that's a big thing now. They have cards that they present for that too. So it's just something else they need to let their clinicians know about, right? But every blood bank will have a quality assurance program, and that is included in the quality assurance, notifying patients of antibody identification, right? So that's so if they identified anti-E at UAMS, 10 years from now, they're traveling on vacation in Memphis and a trauma happens or something, they have to go to the ER, they can let that ER know, hey, I have a previously identified antibody. Then once you and blood bank are alerted, you have to honor that antibody, all right, even if it's not reacting at that time. Okay. Does that make sense to everybody? All right, so back to delayed hemolytic transfusion reactions. Remember, these are not life-threatening. The worst thing the patient's going to have is extravascular hemolysis. The spleen is taking out these antibody-coated cells. Patient might have jaundice, increased bilirubin, and decreased hemoglobin. All right, that's what the patient's going to present with. They're going to have symptoms of anemia. They're going to have tiredness, pale skin. All right, all those symptoms of anemia, and that's the only thing that they're going to have. All right, so if they have received a transfusion, probably either number one, they were involved in a trauma, or number two, they had previous anemia and the unit was to treat that anemia. Well, guess what? Their hemoglobin did not increase. All right. So that's how the physician might also suspect a delayed hemolytic transfusion as well. And then he might request a DAT be performed on that patient. Okay. And so here's your symptoms. Might have slight fever, might not. Tiredness, feelings of malaise, and then again, that jaundice, right, that increased bilirubin. Diagnosis is made, get this, positive DAT, right, because the antibody is now coating donor cells, okay? And then again, that decreased hematocrit, and then symptoms of anemia, including jaundice. KID, like I mentioned, is the one that's most often associated. You guys need to know that. Board of Certification question, they love that question. All right, KID is the number1 associated antibody class for delayed transfusion reaction, just because one of its characteristics is to drop to undetectable levels. All right, however, remember I said, I've seen it happen in other antibodies as well, your RHs, your Duffys, and your Kells, right? They can all drop to undetectable levels, especially if it's been years, okay? What's gonna happen in a delayed transfusion reaction? During our initial blood bank testing on this patient, the IAT is gonna be negative, right? Because the antibody is at undetectable levels. We don't have a history on that patient. We have no way of knowing. All right, so your initial IAT is going to be negative. 10 days later, your patient reports to the physician for a follow-up, and then that doctor, the patient complains of being tired and looks a little yellowish. The doctor's going to order a DAT, okay? And then when we do our DAT and see it's positive, we check our history, notice that he was transfused 7 days prior, then we will do his IAT is now going to be positive, right, on that current sample. Because not only is JKA coating his cells, his donor cells, but it's also his titer is high now, we'll detect it in the IAT. Okay, so that's one way blood bank can determine a delayed transfusion reaction. His IAT was previously negative, his IAT is going to be positive now, all right? So what future recommendations would you put on this patient? Can he still be transfused? Yes. What type of units will you give him from here on out, forever? JKA negative, all right? There's some other concerns with transfusion. Hypothermia is one. Think about what temperature our red cells are kept at. They're refrigerated. And if you think about a massive transfusion where they're given a lot of products in a very short amount of time, that patient can go into hypothermic shock as well. And we actually talked about this in a previous lecture too. A lot of times you'll see in the ER and OR, if they're given a lot of products in a short amount of time, they will use a blood warmer. And this is why, to prevent hypothermic shock. And then citrate toxicity. Citrate toxicity can occur too if a patient receives a lot of products, because are anticoagulant. In those products contains citrate, right? And you guys know citrate will chelate the calcium, so it could cause your patient to become hypocalcemia. Or is it hypokalemia? And one way they treat that is, and this is when your patient might develop tingling lips. That's a symptom of citrate toxicity. They would just give them Tums or a calcium pill. This is only a concern. If you just get one unit, it's not going to be a big deal. This is a concern if you're receiving a large amount of products, all right, in a short amount of time. Because all of your circulating calcium is going to be taken up by the anticoagulant that was in the unit. Right, does that make sense to everybody? And then you guys remember we talked about the storage of products as well. The longer those units are stored, you're going to have increased potassium as well. So if you receive a unit, you could be exposed to increased potassium as well. This is a huge concern for babies because potassium can be toxic for their kidney, all right? So for babies, this is why we try to use as fresh red cells as possible. You guys remember one of the requirements for babies, 5 to 7 days old, or you can wash to remove any of that excess potassium. All right, and then hemosiderosis. You'll see these in our patients that are transfused a lot, such as sickle cell and thalassemia major, right? The transfusion dependent thalassemias. And the only thing is that they receive so many transfusions that they will ultimately have excess iron storage, excess serum iron, so they're in iron overload. One way that we have to treat that is to treat the treatment is to give them iron chelation, okay? So another adverse effect of receiving a transfusion, we already talked about this, is the transfusion-associated graft-versus-host disease, right? And you guys all know how we can prevent this. Irradiation. And so what happens in transfusion-associated graft-versus-host, you have your donor T lymphocytes that can launch an immune response in your recipient, okay? So anytime your patient is immunocompromised or your patient is receiving a blood product from a first-degree relative, right? They must receive irradiated products, and it's just to prevent this graft versus host. And remember, graft versus host disease is considered a delayed transfusion reaction, okay? It's very hard to treat once it occurs. Your patient's going to develop fever, diarrhea, hypoplastic bone marrow, and then ultimately what happens is those T lymphocytes launch an immune attack and start attacking your patient tissues, all right? So if it occurs and left untreated, it has a 90% mortality rate, all right? That's huge. Again, that's why I said it's very hard to treat, easily prevented. So here's some of your symptoms. Maculopapular rash, right? So this is not just like your regular hives. Usually you're going to have large areas on your patient's skin with like a big red area to it. It can have raised bumps as well, like a rash, and it's really easy to tell on fair-skinned individuals, all right? They'll have those red rashes. Fever, nausea, diarrhea, pancytopenia, again, because of the hypoplastic bone marrow. And then elevated liver function test. And again, irradiated products will prevent graft versus host disease by inactivating those T lymphocytes. So they're unable to launch that immune response. So I mentioned our immunocompromised patients, graft versus host is a concern for them, so they should definitely receive irradiated products, such as your patients that are on chemotherapy, your neonatals, all right? So your babies should always receive irradiated products. That's one of the reasons that irradiation is one of the criteria for a baby transfusion. So remember, CMV negative is also a requirement for baby, but that has been replaced by leukoreduction, all right? Because leukoreduction will get rid of the monocytes, which transmit the CMV. So remember, after leukoreduction, those very small mature lymphocytes can still remain in your unit, okay? Irradiation will prevent those T lymphocytes from proliferating, right? And irradiation, like I mentioned, bone marrow transplant patients are considered immunocompromised. Usually they have some type of leukemia, they've had chemotherapy, so they're already in that immunocompromised population. So here's your symptoms and other characteristics of graft versus host. Notice that it is a delayed transfusion, right? Often not even occurring and up to 30 days post-transfusion, right? So that's why it's considered delayed. And you could confirm graft versus host. We could do that in the HLA lab by demonstrating the disparity between your patient cells and your donor cells. All right, so then we have our infectious transfusion. So transmission of infectious diseases is another adverse reaction or adverse effect from a transfusion. And this is why our donor questionnaire, our donor selection is so important, to try to identify those individuals that are at higher risk for infectious disease, whether they initiate or involve in a lifestyle that puts them, or they have been traveling to an area that is endemic of certain blood parasites. And that's why we have our donor selection. If you have a bloodborne parasite infection, such as malaria, babesiosa, it can cause hemolysis. You can see that. And so that's why it will also be considered a delayed transfusion. So some of the viruses that are infected, and we're going to go into the testing of all of these in a future lecture. HIV, hepatitis B and C, all of these have a window. There is a period of time where the patient might have been exposed, but with our testing techniques, we are unable to detect it. All right, so that's your testing window. And in future lecture, we're going to talk about what the lowest testing window is now with all of the newest testing technologies. HIV and hepatitis B includes testing for both the antigen and the antibody, okay? And then hepatitis C is one of the most common transmitted viruses, which leads to cirrhosis of liver, as you guys all know. And then CMV as well. Another reason we give leukoreduced products. CMV is a concern for our immunocompromised patients, like babies. Bacteria, so spirochetes such as syphilis, it cannot withstand refrigeration, but it could be found in fresh blood. All right, and remember, syphilis, you're not deferred for having syphilis because of the condition, but because of the lifestyle that is associated with contracting syphilis. All right, does that make sense to everybody? So if you have syphilis, then you potentially could have other sexually transmitted diseases as well. Not really sexually, but you could have other diseases too. Let's see, gram-negative bacteria capable of growing at 4 degrees. We talked about that. And then gram-positive bacteria as well. More commonly, you'll see gram-positive bacteria in your platelets, such as staph and strep and bacillus. All right, so your parasites. Malaria is a known bloodborne infection that can be transmitted through infection. Chagas as well. Babesiosis and Leishmania has actually been found in those military troops that came back from Iraq. So that is why all of those questions on the donor questionnaire, that's why they're included, is to try to eliminate these parasites from being transmitted. So in the event your recipient turns out that they were transmitted these diseases from a transfusion, it's very important that the hospital and donor facility document that, provide appropriate treatment for those recipients, and notify the recipients, okay? It might be where the donor facility finds out that that unit later tested positive, and then they have to notify all the recipients. Okay, that's called a look back, and we'll talk about that. And that's more with your viruses such as hepatitis B, C, and HIV. So if you have a donor with a previous donor history, previously has tested negative, and then all of a sudden pops up positive, then you have to notify all of his previous recipients that he has now tested positive. So if any of you guys are involved in quality assurance and blood bank, that will be part of the quality assurance for blood bank. You'll be involved in performing those look backs, maintaining documentation of all of that. Sarah says this lecture is enough for me to do autologous donation. Yes. So there's another side effect, and we talked about it before. It's known alloimmunization. All right, so your patient receives a red cell unit, they're alloimmunized, they're going to build an antibody. All right, they won't know they've built an antibody. You don't have any symptoms, but next time you come for blood bank testing, your IAT is going to be positive. All right. There's another prophylactic treatment to being alloimmunized, and it's RhoGAM. All right, so it's you guys all know that the D antigen is most antigenic. It's the most serious causing of hemolytic disease of the newborn for babies. So that's why all Rh negative females will receive RhoGAM at 28 weeks. And what RhoGAM does is it is thought to, number one, there's kind of two mechanisms behind it. RhoGAM is thought to coat if the baby's cells are Rh positive, it's thought to coat the Rh positive cells to prevent mom from being exposed to it. Therefore, it will prevent her from building anti-D. There's another mechanism that just states that it prevents mom, kind of exposes her to the D and prevents her from building the antibody. So whichever mechanism you decide to believe, but it's documented both ways. That is the only antibody that we can prevent from building. So that's the only one that has the prophylactic treatment. There's another side effect, and this usually only occurs if you have had a massive transfusion. So if you have a massive transfusion, that means you've had a lot of blood loss, okay? And so think about blood being lost, plasma being lost, you've depleted your coagulation factors from that. Usually this does not occur unless you have lost one total blood volume. So that's usually about 5,000 mils, right? So in the average 150-pound person, they have about 5,000 mils of blood in their circulation at any one time. And this is why you guys remember when we talked about the massive transfusion protocol, how they give the 1-to-1-to-1 ratio, 4 units of red cells, 4 units of plasma, 1 unit of platelets. This is why, because if you have massively lost blood, you not only lost your red cells, but you also lost plasma. And so if we were to just transfuse you red cells for oxygen carrying capabilities, you have lost your coagulation factors. All right, and so that's why that 1-to-1-to-1 ratio was implemented. So you're not only replacing oxygen carrying capabilities, you're also replacing the coagulation factors as well. Okay. let's see. All right, so this chart is actually in your lecture manual, and it really breaks down your acute transfusion reactions. All right, so you have your hemolytic transfusion reactions, such as the wrong ABO given. You have your febrile, non-hemolytic transfusion reaction, allergic, your hypovolemic, your trolley, and bacterial sepsis. Remember, another word for hypervolemic, meaning increased volume, this would be your taco right here, okay? I like this flow chart. It's also included in your lecture manual. It kind of breaks down. If you decide, BloodBank's going to pay attention to several different things. Number one, when are your symptoms occurring? Number two, what are your post-transfusion, what's your post-transfusion DAT, positive or negative? All right, so if your reactions are occurring immediately during that transfusion or less than 24 hours prior to that transfusion or after that transfusion, then it would be an acute transfusion reaction. All right, if it's greater than 24 hours, it's a delayed transfusion. And then, is it immune versus non-immune? We're going to ask ourselves that question as well. And then you can have immune acute reactions, non-immune acute reactions, immune and non-immune delayed transfusion reactions as well. Okay. And I took this chart from your textbook, so it just further differentiates acute versus delayed. Notice your DAT, all right? In acute conditions, it can be positive or negative. In a delayed hemolytic transfusion, it's going to be positive, all right? Such as our kid example, that would be positive. Okay. The key word there is hemolytic transfusion reaction, all right? So we're not thinking about a delayed adverse effect due to infectious disease transmission or anything like that. It's a hemolytic transfusion reaction, okay? Oh.
Cool. I got it.
I don't know what happened there. The computer was possessed.
Yeah.
It was like osmosis. No, I don't want that.
This all looks like cancer.
Can you click on slideshow? There are goals, topics, and then from current.
Oh, perfect. Thank you. All right, so this just further breaks down what's occurring in acute hemolytic transfusion reaction. So this would be if you receive the wrong type of ABO, okay? So your patient's going to develop hypotension, okay? Think about your ABO antibodies or IgM. They're going to initiate the complement cascade. C9 is going to puncture holes in those cells. It's going to cause cell lysis. So you're going to have intravascular hemolysis occurring immediately. All right. You're going to have red cell stroma. So you're going to have fragments of red cells in their circulation now. Schistocytes. All right. They can get sequestered in the spleen. That could cause abdominal pain. There also could cause renal damage. All right. So that red cell stroma, those fragments, are going to get caught in the kidneys, causing kidney damage. So you have kidney failure. could go into irreversible shock because of destruction of all those cells, decreased oxygen carrying capabilities, and then they could also go into DIC, right? So all of those schistocytes in the circulation is going to activate the coagulation system, and then they're going to have microclots forming throughout their body, right? So that's how serious the wrong ABO is. So the next section of this lecture starts moving into what the blood bank is going to see during their testing. So I'm going to stop here for today. We'll pick up here tomorrow. I know what day it is this week.
I had a question about like the frequency calculation.
Okay.
When we calculate the RH part, do you want it just the D, like the big D, or do you want it?
So on your frequency assignment, you have to look at how your question is worded. So if it is asking to determine the population that matches the RH phenotype, remember RH describes the whole family, okay? So on those questions, you want to include D, big C, little c, big E, and little e. Make sure to pay attention if that patient is D negative, that 15% of the population are antigen negative, okay? Little e, 98% of the population have the antigen. So if your patient is little e positive, then you include 0.98 in your calculation. Okay, I got a lot of questions on that. That kind of, I think, threw some students off. But yeah, so on those, and then if you're looking at the phenotype of a panel cell, you're looking at the whole RH, okay? D, big C, little c, big E, little e.
Calculations don't include the ABO group, only the positive or negative. If it asks for it, yeah.
When you are including ABO, it will specifically tell you. It might say what % of the A population would be antigen negative compatible for this patient. So you have to read your instructions.
In that case, we also do RH as well, or just the ABO and the.
I think if your patient is RH positive and you're trying to calculate frequency on the population that would be antigen negative, we're not really going to pay attention to the RH.
Well, only if the person asks for it.
Yes. If your patient is RH negative, however, you can only work with your RH negative population. So then it becomes an issue. Does that make sense? If your patient's RH positive, they can receive positive or negative. So it doesn't, we won't, remember that goes into play if you're trying to give type specific or compatible, all right? So if your patient has an antibody, blood bank on a normal situation is going to try to give type specific whenever possible, as much as possible. However, if you are dealing with an antibody and trying to find antigen negative blood, we will try to honor the antigen negative rather than maybe give ABO specific or RH specific. Unless they're RH negative, we have to give them RH negative. Does that make sense to everybody? So pay attention to how the question is worded and if the question really specifies, okay? Like one of the questions says, include RH in your calculation. Okay, it will be very specific like that. But if your patient is RH positive and has an antibody, we typically are going to give them whatever units we have that are antigen negative, whether it's RH positive or negative. Now, we try to conserve our RH negative units for RH negative people, but when the patient has an antibody, sometimes it's not possible. Oh yes, you guys don't leave.
Come back.
Okay.